Hello everyone. Today we'll be talking about accelerated idioventricular rhythm and the ECG changes in it. So as the name suggests, suggests that idioventricular rhythm, that is normally in for any heartbeat to occur, our sinus node acts as a pacemaker. So SA node that is present in the atrium, it acts as a pacemaker, and that it is the dominating pacemaker. So all the waves, that's why it will have PQRST. So in idioventricular rhythm means the ventricle will start beating independently to that of the SA node, and that's why ventricle will generate a QRS wave, or called as premature ventricular contraction, or a VPC. So suppose this is a normal PQRS-T, this is a P wave, QRS and T wave, and you can see here this is the ventricular generated beat. So there will be no P wave here. This is the R wave and only ST wave. So this is a ventricular generated wave, and this is called as an ventricular premature contraction. If you see more than 3 beats like this, 1, 2, and 3 in consecutive beats, it is called as accelerated idioventricular rhythm based on the heart rate. So if the heart rate is below 120 or more than 50, then it is called as accelerated idioventricular rhythm. If it is less than 50, it is called as ventricular escape rhythm. And if it is more than 120, heart rate, if it is more than 120, then it is called as ventricular tachycardia. So based on the total heart rate, we label it as either ventricular tachycardia or escape rhythm, or that. So heart rate less than 50 is called ventricular escape rhythm. 50 to 120 is called as accelerated idioventricular rhythm, and more than 120 is called as ventricular tachycardia. So this accelerated ventricular rhythm is generally seen in patients with myocardial infarction. So patient with ST elevation myocardial infarction, once you thrombolize them with fibrinolytic drugs like streptokinase, tenecteplase, reteplase, alteplase. So once you thrombolize them, so during this reperfusion, whenever the myocardium receives this perfusion, or the ventricle receives that blood supply, during that time it starts beating its own beat and produces this idioventricular rhythm. There is nothing to worry if you get this type of rhythm with a heart rate of around 110. It's a good sign. So it indicates that there is reperfusion, or the blockages has cleared. So it indicates reperfusion. So it's a good sign in there. What are the ECG features you see is the patient will have a regular rhythm. Rate will be between 50 to 120. 3 or more ventricular complexes, as I said, more than 3 ventricular complexes, and the QRS duration will be more than 120 milliseconds. More than 120 milliseconds means QRS duration, that is more than 120 means more than 3 small square. And fusion and capture bits. So what are the fusion and capture bits? Capture bit is that in between this ventricular bit there will be normal PQRST. So it's a capture bit. Okay, and the fusion bit is the mixture of the normal R wave with the ventricular ectopic. So fusion of both of them will call the fusion bit. So along with, other than the thrombolysis, post-thrombolysis patient, this type of rhythm is also seen in patients with post-resuscitation, digitalis intoxication, or patient who is on anesthesia. It is also seen in athletes. Management. So this rhythm is generally benign. There is nothing to be done for that. It will resolve on its own, self-limiting. And whenever the sinus node exceeds that of ventricular foci, it will dominate that, and it will subside. It will get automatically subsided. Administration of antiarrhythmic drugs may cause hemodynamic deterioration, and that's why it should be avoided. And always treat the underlying cause. If you find any other cause other than that, that is like myocardial perfusion or correct electrolytes abnormality, so you should do that. So you can see here, this is a accelerated ventricular rhythm. Hope you have liked this video. If you have any queries or any doubt, you can test in my comment box. If you like my video, do share and subscribe with others. And please subscribe to my YouTube channel, Dr. Akif Baig. Thank you.